Hello, everybody. Welcome to Global Response to COVID-19. This is webinar number 8. This meeting is sponsored by the Panamerican Trauma Society, the American Association for Surgical Trauma, International Relations Committee, the World Coalition for Trauma Care, and supported by University of Miami and Virginia Commonwealth University, VCU. I'd like to welcome all the panelists and all the attendees. I'd like to invite Dr. Michel Aboutanos to introduce all the panelists, please. Michael.
Yes, good morning. Good morning, everybody. I will introduce the list of the panelists. Some of them will also be the main speakers, which Antonio will also reinforce. For today, we have distinguished panelists for Dr. Tercio de Campos, President of the Brazilian Trauma Society and Surgeon-in-Chief of the Emergency Service and the Faculty of Medical Sciences at Santa Casa, São Paulo, in Brazil. We have Dr. Juan Carlos Salamea, Professor of Surgery and Trauma and Acute Care Surgeon at Vicente Coral Moscoso Hospital and University of Azuay in Ecuador. Dr. Rafael Barrera, Director of Surgical Intensive Care Unit at Northwell Health, Long Island Jewish Medical Center in New York, United States. Dr. Camilo Ricordi, Professor and DRI Center Director at University of Miami, Miller School of Medicine in Florida, in the U.S. Dr. Ismael Fuanini is the PTS Treasurer, Director of ATLS in Bolivia, Cirujano de Planta and Director General of the Clínica Fuanini from Bolivia. We also have Dr. Christopher Michetti, AAST Critical Care Manager at Large, Associate Chief of Trauma and Acute Care Surgery, and Associate Professor of Surgery of the ANOVA campus of the VCU School of Medicine in Virginia. And we may have Dr. Scalea join us from as the PDS Executive Director, and we may have Dr. Felipe Vega join us as the President of PTS. We do have Dr. Sandro Rizzoli, Editor-in-Chief of the Pan American Journal of Trauma and Medical Director of Trauma at the Hamad General Hospital in Qatar. I believe those are our panelists.
Mike so and Antonio, I'm on.
Oh, hey, Dr. Scalea. So Dr. Scalea, PTS Executive Director, Professor of Surgery at the University of Maryland School of Medicine, and Physician-in-Chief of the R. Adam Cowley Shock Trauma Center. He actually needs no introduction, but I did it anyway.
So we like to show all the associated medical societies that join us. All these medical societies are partners of the Panamerican Trauma Society, WCTC, and WCTC. Some words for this society, Michael, please.
Yeah, I think this is, and you can see the whole list. We mention them every time. I won't go through the entire list, Antonio. I think they're all presented here, and mainly from basically every corridor: the Latin, the Northeastern, the African, as well as European and Australasians. All of those, we have in total more than 19 affiliated societies who are present.
Okay, thank you very much, Michael. So we're going to start the presentation. We're going to have 4 presenters. They're going to give up to 10 minutes talks about the talk, and then we'll have a pool of questions for the audience, for attendees, and then we're going to have a lot of questions answered by the panelists. I'd like to start with Dr. Tercio de Campos, a personal friend for more than 40 years, the President of the Brazilian Trauma Society and Surgeon-in-Chief for the Emergency Service of the Santa Casa School of Medicine in São Paulo, Brazil. Tercio, we're going to talk about what's the current situation in Brazil.
Thank you, Antonio. Thanks, Michael. I'd like to congratulate PTS and especially Antonio for leadership in this project. It's very important for all over the world to keep people together fighting against this. And I'm going to talk about the Brazilian situation right now. I remember the first meeting we had. I told you that we were pretty good, no patients, looking fire all over the world, but we were good. That's not the situation right now. I'm going to show you what's happening here. This data were updated from WHO yesterday evening. And we can see here Brazil, number 9 total cases. And we can see here Brazil, number 3, new deaths yesterday, almost 600 deaths a day. Now we can compare here our curve with USA, Italy, and South Korea, different situations. And we can see that probably we have flattened the curve in the beginning of the disease here, but we don't know where we're going from here to the future. Here, total of deaths, and we have an increasing total of deaths. And here, new cases that we have each day. The curve is consistently going up, so we're very concerned with that. And here, the daily new deaths also going up, so we're very concerned with that. And when we consider mild and severe and critical disease, you can see all over the world we have 2% of serious or critical. In Italy, right now, we have 1% serious or critical. In Brazil, we have 14% of serious or critical. When we see this figure about lethality, comparing all states in Brazil, we can put this line, this red line, to show lethality over 7.5. And we have the red signal in 5 places in Brazil: Amazonas, Pará, Pernambuco, Rio, and São Paulo. And yellow signal in 3, Ceará, Maranhão, and Paraná. And I'm going to show you that this makes sense because of what's happening right now in Brazil and all these 5 red signal places. In Brazil, we have 2 different health systems, the public and the private. The public, everyone has medical assistance by law, but we have too many people and not enough investments, so we have problems with that. And the private, that you have to pay for that. Not everyone has the ability to pay and funds to pay. So most of people are in public system. And now I'm going to see these 5 places, starting with Amazonas. And this is the population, ICU beds, 502. And when we have the 12.3 ICU beds for 100,000 inhabitants. When we compare the public ICU beds, 9.1, with private ICU beds, 34.3, that's a big difference. When we go to other states in Pará, these 2 states are in Amazon region, and we have 11.8 ICU beds per 100,000 inhabitants. The public ICU beds, we have 6.3 in the public system. In the private system, 64.2. That's a big difference. In Pernambuco, we have an increasing number of ICU beds in public and private. Rio de Janeiro, we have 37.9 total ICU beds, and public 14.4, private 87. That's a big difference. And in São Paulo, we have 45 million people here and 26.3 ICU beds per 100,000 inhabitants, and 19.2 ICU beds in the public system, 38 ICU beds in the private system. And this makes a lot of difference. I'm going to show you why. Here we can compare ICU beds with these 5 places with USA, Italy, and France, for example. And we can compare also ICU public beds. And we can see Amazonas and more importantly, Pará, that we can see that we could have a problem here. Just before the pandemic, we can see that. This graphic shows that. And we have right now different situations all over the country. In São Paulo, for example, we have a partial lockdown since March. We have increased hospital and ICU public beds in this period of time. And hospitals are full right now, but there's no chaos. Everybody can go to the hospital and be seen, be treated. We have no chaos in São Paulo. despite the high number of patients with the disease. This is the social distancing in São Paulo since March 22, and about 50% of people were at home, and this probably have helped a lot the situation. Here and mid-March, when we started the disease in São Paulo, and the disease is spreading throughout the state, and by the end of April, but we don't have cows right now. We're concerned about that, but not cows. And there is a different situation in the north part of the country, Amazonas and Pará, the Amazon region, and they're discussing lockdown this week. Maybe Amazonas is going to have a lockdown this week or the next, and Pará will start tomorrow with the lockdown. There's a lack of medicines, PPE, and ICU beds, health professionals infected and out of work. Patients with respiratory symptoms cannot be seen and treated in hospitals due to a lack of hospital beds and doctors. People are dying at home or in the streets, and there is chaos. Let me show you this patient and trying to look for assistance in a hospital. You can see this patient here, and shortness of breath, difficulty of breathing, has not been able to urinate for 4 days and cannot be seen in the hospital. Just take a look at this face, and the ICU patients that cannot be treated. This is in Belém. In Belém, the capital of Pará. This situation was predicted. South America was the last region to be affected, and the preparation time was longer. But those who anticipated the overload of medical service and prepared themselves are not facing chaotic situations. However, those who are working on demand without planning ahead are paying a high price right now. So we have here the perfect storm right now. Cities with high population density, no or partial lockdown. People, in spite of that, want to reopen places partially closed. No national leadership. The Ministry of Health has been fired despite a positive evaluation of 70% of population. Main breaking news in the last weeks in Brazil were related to the president's behavior despite the evolution of the pandemic, which was forgotten. Lack of ventilators, medicines, PPEs, and health professional infected. So that's our situation right now. Despite Brazilian Trauma Society has planned some actions during the pandemic. We started with national Zoom meetings since March, twice a week, to put people together, like you're doing in this meeting with the leadership of the Panamerican Trauma Society. We have guidelines for the protection of health professionals that we spread throughout the hospitals. We have a participation in elaboration of technical standards of the Ministry of Health with support of the Brazilian College of Surgeons. We have talked frequently, exchanged experience with our international friends who have been through this, especially Antonio Marttos and Rafael Barrera, big friends that have helped us a lot through this process. And we have also specific actions in the state of Pará. We have Zoom meetings with Pará health professionals twice a week to discuss and train professionals to the use of PPEs and discuss doubts about the disease. In these meetings, we have the participation of a doctor that's a deputy of the state of Pará. That we believe that's very important to put people together, the doctors with the politics. We believe that's very important right now. We started with a toll-free phone number to guide population about the pandemic. And we have activated the SBITES National Disaster Plan. We have more than 400 volunteers, and we're sending them to the epicenter of the epidemic in Pará. So that we are acting right now. And thank you for the opportunity to share our problems, and then we can try to answer some questions after the other colleagues. Thanks, Antonio.
Thank you, Tercio. Great presentation. The idea today was to show what's happening in Latin America with your presentation, Dr. Salamea, and then have some people that already went over this United States, so Dr. Barrera, and see how we can give some advice and lessons learned when they treat their patients. Let's go now to Dr. Juan Carlos Salamea, a great friend. He's a professor of surgery and trauma critical surgeon at the Vicente Corral Moscoso Hospital, University of Azuay, Ecuador. I had the opportunity to visit Dr. Salamea in Ecuador, and he does an amazing job. He's a big leader in trauma over there. He's gonna share his presentation about what's happening in Ecuador. Dr. Salamea, welcome.
Good morning, everyone. For me, it's a pleasure to can compart our experience in Ecuador. I live in Cuenca. Cuenca is the third city in Ecuador. I'm going to talk more about Guayaquil because you have more information about Guayaquil. This is the epicenter of the pandemic. So, my country have 17.5 million people. This data is about the projection from Census 2010. My country is divided in 4 regions: coast, mountains, Amazons, and Galapagos Island. Like every country in Latin America, we have problems, economics, for example. The 25% of the population is impoverished. Social problems. In the last years, we have many people, refugees from Colombia and Venezuela. It's a lot of people coming to Ecuador. And also, we live, I guess, 20 years with political problems. Guayaquil is the second city in the Ecuador, but is the biggest city and is the most important port by air and maritime. It's about 4.5 million people. You know about the problem in Wuhan, China, and we make the diagnosis, the first case, in February 29. But this old male arrived in Guayaquil from Spain on February 14. In these dates, we have a especially holiday about 3 days, 5 free days, February 21 and 26. March 11 was the pandemic from World Health Organization, and the Minister of Public Health in Ecuador called emergency sanitary in this date. In March 13, Special Operations Committee from government started to make laws in our country. And in March 16, the Ecuador closed borders. I show these slides because I want you can notice the dates. So, this supposed first case in Ecuador was moving 50 days in between 2 provinces in our country. After diagnosis, we didn't know how to appropriately isolate or manage this case. When this lady, after this diagnosis, she was in one hospital, and we decided to move in another hospital. So this patient had to contact with 2 groups of health workers with inadequate personal protection equipment. Many of you know in Latin America, the health workers usually work in at least 2 centers. So start to spread the contamination. Simultaneously, other people like this infected patient coming into Ecuador from different countries for this holiday time, Carnival. And these 5 days, big parties, but really big parties, thousands of people. Many cases in the biggest city in Ecuador, like Guayaquil, was one problem. But the other problem was around 50% of the health workers were positive. and have to insulate and leave the hospitals. The government don't calculate about the real numbers and mandate incineration of the cadavers, but only have the capacity for 8 cadavers per day. Health system collapse. And also with these big problems, deaths from other causes like collateral damage. This is a numbers. In the table, you can see the numbers of deaths in the 2019 and 2010. And in Guayas, is the province of Guayaquil, we have almost 500% of increasing of death. This is the last information from the government. This is the official numbers. We have positive around 30 million people. Deaths about, or today I think is close than 2 million people. And the tests we did in our country is about 18 tests. The numbers don't coincide. This is another problem. We don't have the real situation in our country. In this slide, you can show in the upper part, this is the line of patients in Guayaquil. But now, in these last 2 weeks, we increased the cases in other provinces like Pichincha, Los Ríos, Manabí, and El Oro. The last 3 provinces also are in the coast of the Ecuador. This is the measures from the government. Quarantine, stay at home. We have a curfew. The people moving only 5 a.m. to 2 afternoon. Cars moving by license plate number only 1 day per week, Monday to Friday. The social distancing, and if you have to stay in public places for any reason, you have to use a face mask. This week, these 2 weeks from May, is going to be an evaluation by provinces, and maybe some provinces can start to move. What about our hospitals? The government tried to put hospitals for COVID patients, but this is impossible. So every hospital have protocols and try to divide into 2 hospitals. In the picture you can see is a tent. It's a tent for first triage of patients. We have family doctors or general doctors to see the patients and decide what part of this divided part of the hospitals go to the patients. And also now we have a lot of information about PPE and the personal protection equipment. But the most important is the smart use, because we don't have enough, or we think in the future we can have problems with this. The hospital have a protocols, and we try to homologize the protocols between the hospitals in the provinces. I think you and us have inadequate diagnostic testings because take sometimes time. Sometimes we have to wait 32 hours for the PCR, and we have the problems with false negative. In the south of Ecuador, our university start a protocol for investigation about plasma from recovered patients. Today I am in my university because with many physicians, professors, and experts of our country, we make this book. It's with national protocols from university hospitals. It's about 53 chapters. And the idea is to have updated information to use in Ecuador, and maybe we can use in other Spanish countries or lower middle income countries. Thank you for the opportunity.
Salamea, thank you for a great presentation. We're going to discuss the data at the end, but very alarming. So now I'm going to go to another good friend, Dr. Camilo Ricordi. Dr. Camilo Ricordi is a scientist, the visionary. So Dr. Camilo Ricordi is a professor of surgery, professor at the Diabetes Research Institute, Center Director at the University of Miami Miller School of Medicine. And he has been leading during decades a lot of research in diabetes, and he has a couple protocols right now for COVID treatment. And he's gonna share a little bit what's happening in the research world, what is happening, what's promising, and how research and new therapies could eventually help the treatment of the critical patients with COVID-19. Dr. Ricordi, thank you for doing the presentation. I know we'll have another meeting afterwards. Thank you,
Antonio. Can you see the slide?
Yes.
Okay, great. So, and try to cover a little of the new research initiative, especially what we are doing right now is in progress. As a matter of fact, we have a patient today with this new protocol of umbilical cord mesenchymal stem cell infusion. But to introduce like the general panorama has been, in general, we cannot say that there are a drug or something, an ideal treatment that has been working without any doubt. There are a lot under investigation and some initial promising results, but a lot to be confirmed internationally. If you go, this is from the Milken Institute, but if you look at the current treatments and consideration or vaccine developments, you have a huge volume of both antibody, antiviral, cell-based therapy, RNA-based treatments, and so on. But if you go on clinicaltrial.gov, we have now over 1,170 studies for COVID-19. Some of the interesting ones are on convalescent plasma. There are 49 studies, and for those of you who follow the debate in Italy, there is a very lively debate between virologists and physicians and hospitals, especially Mantova, that did very successful treatment with convalescent plasma. I think it is also to be determined. Yesterday I was at Mount Sinai doing a stem cell infusion in one of their patients, and I asked about their experience. Has not been very positive so far. As a matter of fact, the two patients we treated there with stem cell were both failed convalescent plasma to have any effect. So, but could be useful earlier in the course of disease, or maybe part of a combination strategy. Also, the 169 studies ongoing with hydroxychloroquine. I think the word is not out yet, even if the retrospective analysis paper was a little disappointing, but I know several colleagues that are taking hydroxychloroquine as a prophylaxis, like the 3-week regimen at 200 milligrams every other day. While it's maybe more difficult or dangerous if you have to boost the dose to try to reach levels in a very short time when the patients are already very sick or in combination with the azithromycin. Then there are studies also with remdesivir that is now on the top of the line for attention, also because Anthony Fauci announced publicly the results that have been, in his view, very promising. He cautioned that the data were not a knockout. At the same time, there was a smart primary goal, so they didn't say death as primary goal or recovery, they just said time to recovery. So that was definitely statistically significant improvement that was reduced by 4 days for patients on remdesivir, while there was no significance on the mortality. Even there was a trend, was 80% in the remdesivir group compared to 11.6% in the placebo group. Now, if you go to the cell-based therapies, there are several trials that are under investigation with different cell types, from bone marrow stem cells, allogenic T cells, natural killer cells, and different kind of bone marrow derived or adipose derived mesenchymal stem cell, umbilical cord derived mesenchymal stem cells. And also in clinicaltrial.gov, you can see that the mesenchymal stem cell clinical trial ongoing in the world as of last week were like 9,000 wait if I move this away. Over 9,000 clinical trials ongoing. In COVID, 71 are ongoing, and we have one in Florida, which is a randomized prospective double-blind trial comparing the mesenchymal stem cells to placebo infusion. So this is data from the, I serve on the Supreme Council of Health of Italy, and there are these updates are available publicly on the epicentro.iss.it. And it depicts like the problem. Fortunately, we know many patients can be asymptomatic or with mild symptoms, but if you are in the most severe cases, the progression from onset of symptoms to death, the median is 10 days. And if you are in the ICU, you have 8 days from hospitalization to death, or 4 days if you are no ICU. So it can be a quite dramatic picture, and it has been slowly improving, like I believe now maybe even 12 days from symptoms to death. But what complicates the picture in trials when you evaluate a new research strategy is that the heterogeneity of the picture. You have not only the comorbidities that can affect, you see that in the patients who died, almost 75% had hypertension, 1/3 approximately had diabetes type 2, you have cardiomyopathy, ischemic, and so you can have obesity and renal insufficiency. But then there are other confounding variables. If you see the prevalence between male, female is pretty much the same for comorbidities that increase the likelihood of death. But then if you look overall, men versus women, like up to 59 years of age, you have like 1/4 of the deaths are in women and 3/4 are in males. And then it decreases a little after age 80, and then is a reversal after age 90. But then there is the effect of how many comorbidities there are. So if you have only one, overall the death, the patient who died with one pathology, one comorbidity, are less than 15%. So it means that this 75% hypertension and 30% diabetes, it means these are probably all more than one comorbidity, and you can get into the 60% or more probability of death if you have 3 or more comorbidity. And very often these are like older patients with type 1, type 2 diabetes and hypertension and other problems. So that is why it's important in these studies, like if you do random treatment on patients that can be different of this pathology, even if you have a control group is enough, like it has been shown in one of the hydroxychloroquine study. If your average control group is 7 years older or younger, you can have a different outcome just based on stratification. That's why we are trying to stratify in this randomized prospective trial, also keeping in mind the severity of disease and the ARDS criteria as per Berlin criteria. So this is the trial we are doing now that just started. We have an approval from the FDA or authorization to proceed a few weeks ago, and now we have the first, probably the third subject treated today. They all receive either 2 infusions of stem cells, 100 million of MSC per infusion at the beginning and 72 hours after, or they will receive, if they're randomized to the control group, 2 infusions of solution with heparin but without the stem cell. We give heparin 70 units per kilogram per patients, whether they receive the stem cells or not. And this is the group of terrific group of investigators, multidisciplinary for many institutions that are helping us in this trial, from Giacomo Lanzoni, that has been my left and right arm, and Elina Lineschi for the processing, CGMP, Diego Correa for the studies on MSC, and then intensivist, critical care, Roger Alvarez, Antonio Marttos, and regulatory and biostatistical, and many collaborators also from other institutions, from Case Western, Cleveland, to Duke, to Arizona, to Utah. It's a truly collaborative team. So the reason why mesenchymal stem cells, as you know, are a natural source from the umbilical cord. Each umbilical cord could treat 10,000 patients. You can expand them quite dramatically. They're very good as expansion in bioreactor, but they have all this action like anti-inflammatory, modulation of inflammation, resolution of cytokine storm. They've been described to possess antimicrobial activity, both antibacterial and antiviral. And then, as you know, they promote tissue regeneration and repair. And they tend to home to the site of inflammation, which is something that we don't really need in lung pathology, because MSC naturally, when you infuse them intravenously, they naturally target the lungs. So when we do trials in diabetes or in kidney disease, we have to do selective catheterization, arterial catheterization in interventional radiology of the femoral artery, and then go target the organ that you want to deliver the cells. But in case of a lung pathology, 95% of them go naturally to the lung, and in a situation in which the lung is even inflamed, they tend not also to go to inflamed tissue or site of injury. So we believe most of the cell we infuse of this 100 million will go to the lung. And all the details of this trial are available online, both on clinicaltrial.gov or on CellR4, that is www.cellr4.org. You have the entire protocol, inclusion, exclusion criteria, outcome measure, mechanistic studies, and cell preparation. So anyone interested, I will not bore you with the details of the trial, but these are cells that have been used for several years in clinical trial. We already had authorization of the FDA to test in diabetes and Alzheimer, and this is just an expansion of the same cell type to be tested in COVID-19. Once this COVID emergency will be resolved, we will continue to expand the production of these treatment doses to be ready for distribution to hospitals for a rapid response readiness in case of similar emergency. But also during non-emergency times, this cell repository will continue to serve and support cell therapy for diabetes, Alzheimer, autoimmune, lung, and other chronic diseases that are under evaluation right now. So we're fully aware it's a drop in the bucket effort with MSC compared to the billions that are currently invested by industry on molecules, drugs, vaccine. But in a way, this is simple and more cost effective. In a way, it's a natural resource that we have. If you think that in the United States, last year, a year ago, we had 3.8 million births in the US alone with a rate of 11.6 per 1,000 population, and you consider that one umbilical cord could generate more than 10,000 cell therapy doses. There are no limitations, unlike organ transplantation, when we lose over 11,000 people die in the United States alone for lack of organ donors. We wouldn't have any limitation if we can organize this kind of repositories. So in a way, every healthy newborn baby could save over 10,000 people. And this also is a completely academic, non-profit initiative and very collaborative, open access, and open source. And I thank all our collaborators in these studies and many others around the world from Italy, Stanford, and many places in South America that are joining also with interest in trying this kind of procedure. Anthony Attal at the Wake Forest Institute of Regenerative Medicine with Julie Arlickson are also joining, as well as Georgetown University and Hackensack Medical Center in New Jersey. So stop here, and Antonio, if...
Thank you, Dr. Ricordi, for a great presentation. The idea to have Dr. Ricordi here is to show some hope and to show everybody how we do research, how some of these research have been performed. This research that you just showed, the mesenchymal stem cell, has been a huge collaborative effort with multiple universities and centers around the globe, and including some centers in Latin America that have been joining this study right now. Our last presentation today, Dr. Ricordi may need to leave, but then I'm going to go Dr. Rafael Barrera. Dr. Barrera has been with us for a couple of weeks. He joined the first time while he had the peak of the disease in his hospital. Dr. Barrera is the Director of Surgical Intensive Care Unit at Northwell Health Long Island Jewish Medical Center in New York, and he works with Global Health also. Dr. Barrera treats a lot of patients, and he going to comment what's happening in his hospital and what kind of therapy did he test, did he work, and what's his vision about the future and how what kind of advice he can give to the South American place. Dr. Barrera, thank you very much to join us again.
Thank you very much. Let me share my screen. So this is, as everybody knows, Long Island Jewish. We're part of a consortium of 25 hospitals, and LIJ took the blunt of the Queen's problem with the COVID. I put every Wednesday when we were meeting, we started April the 7th with 711 patients and 152 ventilators. On the following Wednesday, April 13th, we had 723 patients in-house and 110 ventilators. Between the 13th to the 22nd, we had over 850 COVID patients and close to 180 ventilated patients. And you can see the discharge on the week of April 13 was only 12% of ventilated patients. On the week of April 22nd, the curve started to go down. We had 585 patients, 102 ventilated patients, and we discharged over 1,000 patients with COVID. On the week of, as of yesterday, we had 475 COVID patients, 99 ventilated patients, 8 on ECMO, the young ones, and close to 20% of our patients have been discharged that were on ventilators. And we're up to over 1,600 patients that have been discharged. We have an experience of close to 400 ventilated patients in the last 2 weeks. And right now, what we're doing, we're starting to consolidate the peripheral ICUs that we had, because our capacity, as I don't know if for everybody has been following this meeting, our capacity usually is close to 40 ICU patients per day. And we went up to, as you know, close to 200 patients. This is the curve as of yesterday. You can see the daily LIJ bed census. It's clearly the curve is coming down, and in the line below is we are having more discharges than admissions. So clearly, the worst is behind us. The positive thing about treating these patients is that we have medical protocols to treat everything. When we started, we didn't have protocols. It was basically what everybody in the literature or the per se was doing. So now we have 6 medical protocols. Everything is with an IRB protocol. Everything has to be under study. We have one with sarilumab, another with Centivir. That one is closed. That hydroxychloroquine and Pepsid, the plasma trial. There's another trial with tradipitant, and of course the IL-1 and IL-6 trials. So all of these trials are protocolized with investigators and everything, and hopefully by the end of the year, we'll have a clear idea what worked and what did not work. The another important thing that we have done is the end-of-life protocols. Everybody gets palliative care, end-of-life consult. We speak to the families daily with either FaceTime or whatever device they have. They see their patients. They can come into the hospital, and we speak to them. So everybody gets a palliative care consult, and everybody has advanced directives, which is very important to do. We have a tracheostomy protocol now, which basically most of the tracheostomies, if not all, should be done in a negative pressure room on patients that are COVID negative, and we do percutaneous trachs. So all the ICUs are being used as ORs for the tracheostomy, as well as a gastrostomy. Everybody has a gastrostomy protocol also. And the most important thing that we're doing is we're creating a follow-up COVID critical care clinic for patients and families. That I think is going to be a big success, because we don't know these patients, how they are going to be in the near future. What we know right now is that they're very weak, and their cognitive senses don't come back for at least 2 weeks or more, if that. The other thing that we have not discussed in these meetings is the possible post-traumatic stress syndrome of the nurses, physician assistants, and physicians. And we have a very strong psychological help for the staff. And we had a program of compassion fatigue in the surgical department, which have expanded now to everybody. So everybody there's a hotline that you can call if you're stressed. There's people from the chaplaincy, from psychological help for the staff that might be overwhelmed with what's going on with the death and overworked and everything. So right now we have 2 nurses per 2 patients, in comparison of 2 weeks ago, which we had 4 critical care patients for 1 nurse. So we are starting to redeploy all the teams that we created, and hopefully in 1 or 2 weeks I'll have even better news. Thank you very much.
Thank you, Dr. Barrera. I'm gonna like your comments at the discussions phase about the treatment. So let's go right now for everybody. We're gonna have a pool of questions. Please, everybody, take your smartphone and your laptop. We're gonna have 10 questions, and then gonna guide the discussions of the panelists. Valera, can you launch the pool first, please? Okay. So first question: what kind of medication have you been using when the patient is admitted to the hospital? Not the ICU. Once somebody's sick enough to be admitted to the hospital, what kind of medication are you using? These are multiple choice questions. Choose all that you have been using, okay? Question number 2. What kind of medication are you using once the patient is in the intensive care unit? What kind of medications or treatments or approach do you use once the patient is critical in the intensive care unit, okay? Question number 3. How often do you see patients with COVID-19 that are in the critical unit having some thromboembolic events? DVT, pulmonary emboly, myocardial infarction, stroke, some line thrombosis, or limb ischemias? How often do you see this patient having these thromboembolic events, COVID positive in the intensive care unit? Number 4, when did you start full anticoagulation for COVID-19 patients? As soon as they are admitted to the hospital, when admitted to the intensive care unit, once the patient is sick enough to need intubation at the intensive care unit, or only when the markers like D-dimer goes up, or never do anticoagulation, okay? Next question, number 5. Which medication that you have been using, okay, for the, did you truly believe in making the patient improve? Which medication do you have a feeling that they are helping patients, okay? Please let us know from all this medication or treatment that they're using, what is helping your patients. Multiple choice, this question. Number 6, if you are using ECMO, right? Extracorporeal life support, so oxygenator. So how do you think it's helping the patient? Significantly worse in the patient, slightly worse and no changes, slight improving on this patient, significant improvement. If you're not using, just put not using the therapy, not using ECMO, or you don't know what's happening in your facility. Another question, number 7, are you engaged, is your institution engaged in any research activity? If you have any study, please select all the ones that have been used, okay? Convalescent plasma, mesenchymal stem cells, sedenzimir, plasmapheresis, steroids, or any other, please send me, please put here, okay? Any research study. Question number 8. Once you have a patient mechanical ventilation, which day is the day that you can say this patient gonna turn around, they're gonna be doing better, or after 7 days, 14 days, 21 days, you say, no, this patient not gonna improve, there's low chance of recovery. So do you know when you have an idea if the patient is going to do well or not, and if there's a date is around 7 days, 14 days, or 21 days intubated or mechanical ventilation. Next question. Especially for places where you have a lot of patients and not a lot of ICU beds or ventilators available, do you have a protocol to choose who would go to ventilation, mechanical ventilation, who would not be a candidate for mechanical ventilation? I believe some place in Brazil or in Ecuador, even New York, they may have that or not. And last question, besides lethality of disease, age, and comorbidities, do you see any other reasons that are affecting survival of COVID-19 when the patient is admitted to ICU? So if the patient are poor, you have an increase of mortality. If they don't have access to ICU care, if you are having a critical care patient being managed by non-critical care specialists, sometimes you have a lot of people from other specialists taking care of ICU patients because they have more beds available, need to create overflow beds. Or you don't have these professionals available to take care of these patients. Or you don't have enough ICU equipment or PPE or ventilators available. Please select what you think that's involving in the survival of these patients with COVID-19, okay? So these are the 10 questions. Please finalize these. After finalizing all the questions, please say submit. So once you submit the questions, your answer is going to be in the pool, okay? Okay, Valeria, people are answering this.
39% voted, doctor.
Okay, let's give a few more seconds. So after everybody answered these questions, we're gonna go to the question and answers. So Valeria gonna keep these questions, the results on the main screen. Dr. Aboutanos is gonna quickly summarize the results, and then we're gonna go to questions and answers. We're gonna have 30 minutes, about 20 minutes of questions and answers. We'd like to use our panelists to discuss the topics today, okay? So Valeria, can you please end the pool? Dr. Aboutanos, your comments on the answers, please.
So the first question, what are the first-line medication treatment for COVID admitted to the hospital, not only to the not to the ICU specifically, and you see the majority are using the hydroxychloroquine, although just about everything else except ribavirin is being used. It's interesting that full anticoagulation is about 22%. I wonder how many of those are in the ICU or not. But that's the answer for the first question. Tony, you want to go to the next question, go through a summary of them, or what do you want?
So Michael, I think you can go to all the questions, and then
okay,
I think we can go to all the questions, then they can comment, start to ask.
Sure. So in the second question, this is whether for the intensive care unit admission, and you could see it's still hydroxychloroquine, it's still the highest level, but now you start to see prone positioning about 61%, which is kind of the second highest, and you still see just about everything else has been tried. Something I've been talking about. There are too many solutions to an answer. That means we don't have one solution to the answer. So it's a combination of everything. It's a bundle. That's what's been shown from everybody's answer below. Number 3 was how often did your COVID-19 patient in the ICU have clinically significant basically DVT or PEs or MI? This is a very important question. Many of us are dealing with this, and it's interesting that the majority are saying this is rare, about 36%. It's totally the opposite of another group of the people who've answered, 12 versus 13, basically saying 33%. So a lot of variability in what people are seeing, and I'll have to say what's actually being attributed to the COVID-19 versus what actually already is present. And 25% are unknown. Number 4, when you start your full anticoagulation to COVID-19, what is the time that you started? And about a majority here, and I'll have to say our institutions included, is only when markers like D-dimers goes up, something that would indicate that you have active thromboembolism going on. And this is not some do go by criteria of you as soon as you get admitted to the hospital, which is interesting, about 11%, and 14% about when you were admitted to the intensive care unit, period. And a few said it's unknown. Going to question number 5, please select the medication treatment that you are using and believe that's actually making a difference, making the patient improve. Again, you see the highest here is prone positioning, not a medication, but a treatment that majority are finding that it's making a difference, as well as hydroxychloroquine still being mentioned here, which is interesting despite a lot of the conflicting results that you were seeing in the literature on this. And then there is a slew of everything else we've mentioned. And again, maybe the most honest answer is on the bottom, which is unknown, how a patient get better besides just ICU care and proning. That's my bias. I go to number 6. How do the majority of your patients treated with basically extracorporeal life support like ECMO, etc., based on those that have them? 50% say they don't have it, so they can't comment. This is the interesting part. Of those that do use it, they're seeing either a slight improvement or no change. When you put those together, that's the highest number when you combine that. And that's basically what most people are seeing with regard to ECMO. Are you engaged in any research and activity? And you will see that there are majority don't know what who's engaged, who's not, but there is some engagement with convalescent plasma, remdesivir, and a few with others that are noted. Now, with regard to mechanical ventilation, what day do you believe the most appropriate one to indicate whether the patient will survive or not if you are on and most people land around the 2-week aspect, about 36%. Some say maybe after 1 week. But I believe maybe again, the most honest is about 33%. I guess if you survive to 21 days, you're already self-selected. Number 9, do you have a protocol guiding who's eligible for intubation? And by now, which I think this is a good answer, about 67% says yes, we do. Those that have no, I would strongly encourage that you reach out and actually use all these protocols. Don't reinvent the wheel, and they're everywhere, especially when we're talking to our colleagues from the Latin American region. Number 10, it's the last question. Besides the lethality of the disease, age and comorbidities, what other reasons you suspect are affecting the survival of the COVID-19 patients admitted to the ICU? And here, I think this is universal. About 67% had access to ICU care. And that actually came from our previous webinars, specifically from Italy and from China, indicating that this is really the most effective aspect. The other part is if you don't have any ICU equipment and appropriate PPE, that I believe this is a big issue, probably relates to personnel being at risk. And the personal wealth is something to be looked at further. I think that's part of access to care. And of interest, that 25% at ICU being run by non-critical care trained physicians. As we know, there's been a couple of studies and a couple of experiences, especially from a couple of New York hospitals that have used non-critical care trained physicians. So it'll be interesting to see how that develops. This is basically another question, sorry, about 40% almost, lack of enough health professionals to treat all incoming patients. So basically, having the right personnel and having the personnel that have access to critical care, that will affect survival. So this is a quick summary, Antonio, of everybody's answers. But I think they're very candid and good answers.
Yeah. So Michael, my first question for the panelists, and then you can direct it who's going to answer. So we saw during the presentation for these last 2 months that the place where they have time to prepare and then the number of patients in the critical care don't reach the capacity, usually they have more time to treat and the survival rate is a little bit better. In places like we are having right now in Brazil, there's a report in Ecuador where the amount of patients, the severity of the patients go over the capacity of the response or the beds or the ventilators is a critical situation. So Dr. Barrera for New York, he had, like in Miami, you never went above 30% of our capacity for critical care, for example. And we are right now in a plateau in the curve, and then we are reopening some services, and we're opening for elective surgery. So I will start, Dr. Barrera. Dr. Barrera, how do you see the response? So what kind of device they place the countries that you're going to have a peak like you had? So what should they do, and what kind of mistakes should they not have, or what are the main lessons learned that you can tell them? There's some places in South America that had some time to prepare, but they're going to have like the big wave right now, or maybe the peak in a few weeks.
Thanks. I think the most important thing is to have a disaster plan, which every hospital should have. If you don't have a disaster plan, SCCM actually has a booklet on disaster management. The most important thing is to be prepared with teams. So what we did here when we had the surge and we went up to close to 200 critical care beds, we had one, and I showed the slide in the previous presentation, we had one critical care attending managing 3 critical care teams of non-critical care surgeons and physicians, and with critical care PAs. So basically you were managing close to 60 patients or 50, and every team was managing 13 to 15 patients with non-critical care with direct instructions on how to manage it. So that's one thing you have to do, the creation of teams that are composed by non-critical care physicians. The other thing that's important is bed capacity. Where are you going to put these patients? You have to have a plan to do so. What we did is we put most of the patients, and we called it the COVID Central. And it was in an ICU, which had a capacity for 60 beds. Of course, for that, you need money, and you need infrastructure, and you need to be prepared. But you have to think of all these things. Where are you going to put the patients, who are the teams, and who's going to take care of it? The most important asset are the nurses. So if you don't have the nurses, you have to start planning for a nurse to take care of 4 and 5 critical care patients at the same time. And then what happens is what we found, there was no time to document anything. So they just documented patient alive, vital signs, and there was no large documentation that we have in the US with Sunrise or Epic that takes hours and hours away from the bedside. So those 3 things. But one thing you cannot forget is communicating. Whoever's in charge has to communicate well with everybody else. The first fatality in a disaster is communication. So you have to communicate well. You have to be very clear on where, and after that, you will be fine. So communication, the leader should be a physician, should not be an administrator. Administrators should administrate and get assets, get everything in place. And whoever is in charge, the head of MICU, the head of SICU, the head of trauma, should be managing all the assets, all the space and the equipment.
Thank you, Dr. Barrera. This is a very, very important, I think, and valid question. This goes back, before we get to the Q&A, I'm going to ask the question to Tercio and to Juan Carlos to get the Brazil and to get the Ecuador experience. So as mentioned by Tercio, you had some time and you knew that Latin America was going to be kind of the last to get hit. So you had some time, yet you described a very dire situation already in Brazil. And Dr. Barrera mentioned 2 important aspects of all hazard approach, which is communication and coordination. And those 2 are the fundamental of anything else, whether you're putting teams together or not. How do you think those are being applied in Brazil? And then I will ask the same thing with to Juan Carlos with regard to Ecuador in terms of affecting where the surge is and how soon you could reverse the process, at least into leveling the plane. Tercio?
Yeah, thank you. This is a very important part of the preparedness for disaster. Some parts of the country, I can tell you, São Paulo, for example, we have prepared for that. And we have, for example, surgeons right now are working with COVID patients. We have been trained before. So because of this, we don't have calls here. We have improved our ICU beds, our hospital beds as well. And so because of that, we don't have calls. By the other side, some parts of the country, and we didn't have that like it should be have done. So we have a damage control situation right now. So that's what all we can do right now is to look for lack of resources and try to help that people and to try to influence in the command of the situation. And so it's very hard in those places that haven't prepared before of the pandemic. So it's a very different country. A lot of countries inside the whole one.
Maya? Dr. Telemea, and can you answer with regard to Ecuador experience on this?
Yeah, I can talk about my hospital. My hospital is the biggest hospital in the south of Ecuador and covers 2 million people. Our hospital prepared a big plan. Big plan with 4 stages. The first stage was with 70 patients ventilated. The second stage for 10 patients ventilated, and now we are in the third stage with capacity of 30 patients. And the last, and we expect don't have this stage for 70 patients. So we are moving beds and all of the supplies for the COVID area. And also we have to closing areas in our hospital and moving doctors, physicians, nurses for the COVID area. The last 3 weeks, we have around 30 patients and 10 of these are ventilated. We don't have more numbers than 30 each day, and we expect don't have more because Real Hospital is the regional hospital. The idea was to convert a COVID hospital, but it was impossible. And the other part of the team are doing the rest of the surgeries for emergencies and trauma. In the first weeks, we have 5 or 6 patients and 1 or 2 surgeries. But now we are seeing at the emergency room close than 100 patients, and also we already done 10 to 15 surgeries each day.
Great, thank you. I wanted to, we didn't have a chance to ask Dr. Fornini from Bolivia. Have you seen something different from what's mentioned in Brazil and in Ecuador? Not sure if this,
thank you, Michael. Thank you, Michael. Actually, listening to Tercio and Juan Carlos speak about the experience in Brazil and Ecuador, there's a lot of similarities in regards to lack of coordination with between the private and the public sector. And the one thing we've done well in Bolivia is that they've actually curtailed, or we started on lockdown about 6 weeks ago. And over the last 4 weeks, we've been on complete lockdown to the point where you're only able to be outside from 7 o'clock until 7 o'clock in the morning, 2 o'clock in the afternoon. And people can only go out once a week from Monday to Friday, and there is nobody's allowed outside Saturday and Sundays. And they're controlling it by national ID cards. In my institution, we started working on protocols in February, and that's made a tremendous difference. Despite the fact that we're a small private hospital, we are a reference hospital for Santa Cruz, Bolivia. And currently, Santa Cruz, the department or state, has over 1,000 cases, and there's 1,800 for the entire country. So even though we're 33% of the population, we're roughly 56, 58% of all the COVID cases. Of those, roughly 6 to 8% have been taken care of our institution, and on any given day, about a third of the patients who are in the ICU or intubated are being taken care in our unit. Because of the planning and preparation at my institution, our mortality rate has been very low. We've actually only had 1 death. And We've been able to extubate patients who've been in the ICU, and these would be considered high-risk patients. We're following general guidelines with, we give patients in the ICU hydroxychloroquine. We also give lopinavir, which is antiviral for HIV, and we do not do antibiotics on all patients unless they develop a secondary pneumonia. The problem is that the other institutions, especially the private ones, have failed to prepare for this contingency. And we've had a couple of patients arrive into our emergency room, citing 70% in dire situations who were rejected by different public or private hospitals that were unwilling to take care of COVID patients. So the main issue we're having right now is that only few institutions are handling them, few have prepared, and we are not having more problems because we did an early lockdown. But as the cases continue to increase, and over the last 4 days, we've had 100 new cases each day, which last week we only had 20 roughly each day. I think the situation is going to become difficult and hopefully not as bad as Guayaquil.
Thank you, Esteban. We have a lot of questions in the Q&A. I would like to ask the panelists to keep answering the questions to the audience. Then I'm gonna make some questions afterwards to Dr. Micheli and to Dr. Barrera about what's working. But before that, I'm gonna ask Dr. Thomas Scalia to make his comments about the presentation, the current situation. Dr. Scalia, please.
You know, great discussion. It struck me as I was listening to the various people talk that most hospitals and even most healthcare systems have attempted to prepare, but they have done it in the ways that they have always done things. For us, normally what we would do is transfer every sick person to the mothership. And we made a conscious decision not to do that. We've got a big healthcare system, 15 hospitals, and we decided early on to distribute all of the COVID patients, including those that are on ventilators, across all of the ICUs. And we reserved the Shock Trauma Center, for only the people that were the sickest. This has allowed us to do things differently. And we are now, we have some capacity, so we never say no. We always have a bed. Last week, for instance, we had 18 people on ECMO. And so we have the ability to do that because we didn't take everybody downtown. And it strikes me that these times are opportunities for people to think about different ways. We are working on a statewide system to distribute patients. We should have a central clearinghouse and know who has beds and who doesn't. We created statewide strike teams to go to the nursing homes early, before they were overrun with COVID patients, in order to try to make some decisions about who would get care, who had advanced directives, just trying to take a much more systemic approach to this rather than keeping all of the decisions local.
Very important comment, Dr. Scalia. Brazil and Ecuador probably they have big network, and they can explain later what they are doing for that. Dr. De Campos, there's some questions for you here on the Q&A. There are two questions. The first question, can you comment the first question? Can you read and comment the first question? One is regarding what to do when people that in the favelas, where they have water, don't have food, etc., and they cannot self-isolate, and what about what's happening with the Brazilian perspective? There's a movement, Brazil Without Fear, and some political challenge in Brazil about doing social distancing or not. So can you comment about that, please? There are two questions in the Q&A about that.
It's a big problem because we have favelas and a lot of people living together, pretty close one for each other. And it's hard to deal with that. And those people need to go out in the morning to have food in the evening. If you don't go out, they can't eat. So it's a very difficult problem to solve. Because of that we need a leadership to determine what you should do in different situations in the country. We have a lot of different situations here, and we have to deal nationally with leadership to at least keep most of people at home. People that could stay at home should stay at home. But people don't know if they should go out or stay at home, because each government say different things. So it's hard to be who's going to believe and which person we're going to believe. So and that's very difficult in the country. We're going to pay a high price for that.
Dr. Salamea? Dr. Salamea, what's working and how to keep the social distance in the poor population?
It is very difficult, especially in the coast, because the people who living in the mountains is more easy. They have enough land around their house. Also, they have enough food. It's easy. Have eggs, milk, and other vegetables from their own. The problem is in the coast. Some places in Ecuador, like Guayaquil, and also the favelas in Brazil, have the same problem. It's almost impossible to say stay in home, because the home have a big problems. Maybe this is one of the biggest problem in Latin American countries.
Great. I'm going to switch a little bit the question for Dr. Micheli, Chris. What in your experience, especially with the NOVA system, from a critical care standpoint, how do you think, what has worked the most? What advice can you give others?
Well, we have in Northern Virginia, we have a 5-hospital system at Inova, and our experience kind of, as like Dr. Barrera alluded to, having an organized approach and having some time to prepare really helped us. So we learned from the experience of other sites in the US that were already being hit with a lot of COVID patients, and I'll try to take an organized approach, kind of like a trauma system. I think, you know, we trauma surgeons are familiar with the benefits of having a system in place. And so we had an opportunity to create triage systems. So we knew when patients were coming into the ER, we knew where they were going to go based on their severity. We knew who was going to take care of them, what team. And when they got there to the ICU, we had protocols in place for what treatments they were going to get based on severity of illness and different markers like D-dimer for anticoagulation and things like that. And these have actually changed over time, over the last 5-6 weeks. Many of these processes have changed. So I think being adaptable was also very important. So having systems, having protocols, and then being adaptable to the situation has helped.
Great, thank you so much. I'm gonna look at some of the QA questions that have been asked. One for Dr. Barrera, who said he would like to answer the question live, is what does it mean when someone's ventilated and can discharge home? I think that's what the question is saying.
And also a comment about heparinization and thromboembolic events. There's another question about that, Dr. Barrera.
Right. So discharge home from vent was patients that were in the ICU on a ventilator that actually went home, that walked away from the hospital. So that's a very positive number, because it's close to 20% in our case right now.
Mm-hmm.
So we were very happy with that number. We still have close to 100 patients that are now most of them over 2 weeks, so we have to make hard decisions. Who's going to be tricked and who's going to be have a very tough end of life decision and making a conversation. And with the heparin, everybody gets heparin at admission in the ICU. We try to give Lovenox. We follow the creatinine clearance, and we follow the D-dimers. If the D-dimers start going up, we heparinize the patient with anticoagulation, maybe to around PDT around 70 or 80. What we have found is, and this is empiric, that patients that tend to coagulate more with propofol. So we are not using as much propofol for long-term use as we were at the beginning of the crisis, and that has decreased, in my opinion. But this is not scientific; it's just empiric, that we have less coagulation problems with lines, especially, and DVTs. We have not been able to scan everybody or do an ultrasound of their legs or to see if they have DVTs because of the quantity of patients. Now we're starting to do that on a daily basis because the number of patients have decreased. But we have a very low threshold to give TPA, to give a heparin IV, and we have a very low threshold to give TPA with patients that we think had a pulmonary embolism. We just do an echo. If the ventricle is dilated and more hypoxemic than usual tachycardia, we just give TPA, which in some cases have been with very good results.
Interesting questions. How do you keep your family member isolated? And you know, we see a lot of these different things as far as you know, do you wear a mask? Don't you wear a mask? Do you just stay in the hospital? What's been the experience? If we kind of go back to Dr. Barrera a little bit with your experience in New York, what has that been?
Well, we, you know, our experience with family members who are positive and the rest of the family is not, we ask them to be isolated with hopefully an N95 mask or a mask in their own room, and to be very careful with interactions and clean and have a very clean environment. The same thing, the same rules come with the staff. You know, we at the beginning of the crisis, we had a lot of staff members that got infected. Now we don't see that anymore. It changed. Either we learn how to wash our hands, we learn how to put our PPEs, or the virus has changed, because we have not seen any member of my team being infected. We checked our antibodies, and most of the old attendings, me included, are antibody negative, which is very fascinating. The guys that got sick on my team were at the beginning of the first week. And when they got sick, or they were in contact with patients that were sick, or family members that were sick, were isolated with an N95 mask in their house. It started with 2 weeks. Now it's down to 1 week, 7 days.
Interesting. You know, we're gonna publish some of these very nice answers that we also have. Those would be on the website, especially with regard to the family care. There are additional interesting answers. I do have one question that, as everybody predicted, you know, the weather, at least here in VCU, is getting nicer, so we're getting some more and more trauma. And we did have one trauma patient that I dealt with that was positive and did require a stoma from multiple gunshot wounds. And so the question came in: how do you manage a stoma in the COVID patients? You know, there's a lot of experience with regard to the trach. We debated this back and forth. But how about a stoma? Is there anything different? At Scalea, you guys did anything different? Have you seen this in Baltimore? Trauma and COVID positive and a stoma?
We've seen more than a few, and we have not treated them particularly different, Mike. We have not done anything special.
And Dr. Scalia, since you are talking, so what's your comment about ECMO? What's the time to indicate ECMO for this patient? So for the multiple patient that you have put on ECMO, so what's the experience in shock trauma?
Yeah, we don't have an exact protocol, Antonio. We're aggressive early with ECMO at 5, 6, 7, 8 days. If they are if they're worsening or not improving, we ask the question, are they a candidate for ECMO? We decannulated 2 people Friday, I guess. So far, we still have 10 people on, but so far they seem to be improving. a little too early to tell, but we think it's a pretty good rescue therapy.
Thank you. I'm going to have the last two questions for the question going to be Dr. Barrera and to Dr. Rizzoli. Dr. Rizzoli has been in the hospital in Qatar that received all the patients, all the traumas, and all the intubated patients, and the critical care patients with COVID also. Question Dr. Barrera, and then I'm going to go to Dr. Rizzoli. Dr. Barrera, what's working? What's your treatment right now? What kind of medication or treatment protocols have you been using right now after all these months, all these patients that you treated? So what's your preferred management of these patients right now?
Well, as we saw in the slide, there was a disclaimer, right? We still don't know what works. But from what we are seeing, if you give the medicines early in the course, the patients do a lot better. And I think the hydroxychloroquine with the Pepcid is a good drug. It seems like the remdesivir might work, and one of the interleukin 1 or 6, maybe the toci. We've only seen in my institution close to 500 ICU patients. It seems like toci seems to have a better effect than the rest, but I have to look at the data and everything. But I think the earlier you treat the patient, and the better. But one thing that really works is proning. Proning for sure. Proning early. And one thing that's interesting is a lot of the patients that we've seen are hypoxemic and have no symptoms. And I think it all depends on the level of the hypercarbia and the pH when they get intubated. But that will be my answer. I don't know, but I think if I was a patient, I'll definitely get the hydroxy with the Pepcid plus the remdesivir.
Thank you very much. Dr. Sandro Rizzoli. Dr. Sandro Rizzoli, Chief of Trauma at Hamad Hospital in Doha, Qatar. He's also the editor-in-chief for the Panamerican Trauma Society magazine, journal. So Dr. Rizzoli, your comments about Qatar and your message from the Panamerican Trauma Society journal, please.
Okay. So Dr. Marttos, Dr. Aboutanos, thank you very much for the opportunity. Concerning what I think it's working, I personally think that the best is still good medical care. It's having a good ICU, qualified people, aggressive and early treatment. The more I read about medications and new drugs, the less I'm convinced that actually they are the real changers. I still think that's probably medical care. As Dr. Scalia mentioned, I think there's a role for ECMO. We're seeing some reasonable results, that's our impression, but it has to be given early, the same thing with intubation and many other strategies. So I'll be very happy to talk a lot about Qatar. Qatar is quite unique and different. I look at Dr. Tercio talking about Brazil, Dr. Salamea, the experience of Esteban in Bolivia, and even the US, and Qatar is unique, quite different. And I'm not going to go in there. Basically, today I'll talk on behalf of the Pan-American Journal of Trauma. What we're seeing is a new disease that has completely disrupted how we practice surgery, how we practice trauma and critical care. So the Pan-American Journal of Trauma is very interested in publishing works on COVID-19 and its effect on trauma, surgery, and critical care. So this is an open invitation to all here to consider submitting their work on COVID-19 to the Pan-American Journal. We will expedite any COVID-19 papers. We will do a fast track and publish them online very expeditiously. We are even creating new forms for you to submit your work, like we want brief clinical reports, surgical perspectives, case reports, and we'll consider all the submissions. So the Pan-American Journal is quite open, and this is an open invitation to everyone in the world to consider the Pan-American Journal for its work. Thank you very much for the opportunity, Antonio and Michael.
Thank you, Dr. Rizzoli. So just to update everybody, next week you're going to be talking about trauma care during COVID pandemic. As you know, traumas are going up as the countries or the states are reopening or you have some issues happening. So we're gonna see how to take care of trauma patient, when a trauma patient can be a COVID patient, and how to surgery, how to manage the patient in trauma bay, etc., etc. We're gonna have a lot of good trauma centers connect next week discussing this topic. So Michael, please, I would like to ask Dr. Tercio de Campos and Dr. Salamea their first comments, their first speak about today's topics, and then you can make your comments also, please. Dr. Aboutanos.
Sorry, I was muted. Can you hear me now?
Yeah. Yes.
Okay, Tercio, I think you already saw Antonio already asked a question, please.
Tercio, your final talk, please.
Okay. I'd like to thank you for the opportunity to talk about the problem in Brazil. It's a big problem for in other countries. Good fact that is we have to go through this problem by this way, but that's what I have right now. So it's very important to share with you all the problems and to learn from you as well. Thank you very much.
Thank you, Tercio. I think the same way as we followed Italy and with the surge and the follow-up, we think of a follow-up on Brazil and find out where you guys been at and how are things progressing in this in Brazil. How about Dr. Salamea? Closing comment from your end?
Thank you for this opportunity. It was a pleasure to have this talk with all of you, looking the different realities in our countries. I expect in the future, in the weeks, in the months, we can have more information and good protocols for attend the COVID patients. Thanks again. Thanks for this time.
Great. Thank you so much. I actually was gonna also leave with one comment that actually came from Tina Gardner, and who has been on our panel many times before with regard to Norway. And she just sent this one comment. She said, she's really interested in the way these meetings are helping all of us develop an understanding for the global aspect and diversity in experience and challenges. And I think this is the biggest aspect, probably what we have done here, whether on purpose or inadvertently, is seeing the different progressions and the ability to learn from each other and knowing very well that what may work in one area may not work in a different area, and learning how the different approaches that we could have. So we appreciate everybody who has contributed. We will be putting answering some additional questions from online, and we thank actually obviously all the time thanking Valeria and thanking Gladys and all the supporters for our ability to put this online, especially University of Miami with this platform. Antonio, I'll leave it to you.
Yes, thank you, Michael. Thank you, all the panelists. Great discussions again. In the name of Panamerican Trauma Society, the American Association for Surgical Trauma International Relations Committee, the World Coalition for Trauma Care, University of Miami, and Virginia Commonwealth University, VCU. I'd like to thank everybody for participating. We are learning with each other global-wise. And I would like to applaud Valeria, Gary, Gladys, all the people that behind the scenes have been helping to make these meetings happen. Meet you all next week, and I hope everybody stays safe. Thank you.